which means that the knee is going to be flexed over. Can you see on this mannequin how it kind of opens up the buttock area? So you can see the anus. But you want to keep the patient covered. And once we show you this, we're going to play a video, and it's going to show administration of a fleets, and it's going to show administration of a high volume enema. Now, how much did we say is going to be in a large volume? 15. This bag holds 1,500, but usually about 500 to 1,000. Okay, and the water just goes in through here. Do we use tap water or sterile water? Or
tap water.
Just tap water, right. And you can put the soap in first, but you just don't want to suds it up. So I always like putting the soap in after I put the water in. But you put the water in, then you put the soap in, just kind of knead it. And then you purge the line. And what does purge the line mean?
Get the air out.
To get the air out of the line, because we certainly don't want to administer air to the patient. So you can hang this here. Once I get started, I like taking the bag back off of the IV pole. But remember, if you hold this above the bag, it's not going to flow out, is it?
Mm-hmm.
But as you bring it down, it's going to start flowing. The best way to kink off your tubing, though, is just to kink it off with your hand. Now, when we do this, we're going to have you use a bedpan, and the bedpan is simply for the purpose of collecting your water, so that we're not actually putting it into the mannequin.
So it's not part of the actual procedure, so you don't get water everywhere. That's all. We confused some people last time.
Yeah, they felt like that was part of their equipment that they needed to gather for the skill, and it's not. So we're going to get the patient position. We're going to have the room set up. The temperature is going to be comfortable. We're going to have a pathway clear to the restroom so that when they're ready to go, we don't have any obstacles in the way. You want to get the bed, really the rectum, you want to get about waist height for you. And then the tubing comes pre-lubricated, but you can add more KY jelly. Now you can kind of see how that looks a little bit milky, hazy, just because it has the KY jelly on it. You're going to wear clean gloves. You don't need sterile gloves for this procedure. And we're going to insert this into the rectum. How far do we go in?
2 to 4.
I'm good.
3 to 4. Ding, 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 ding. So, you said 2 to 4. The 2 would be a little shy.
Why is that?
Which
Gotta
sphincter?
get through which?
The internal sphincter. And
If you don't, what's the purpose?
None. It comes running back out.
Yeah, you gave an anal's.
Enema. Right, it's just going to stay in the rectum. All right, so it has to get beyond that to get up into the colon. What direction are we going to insert it?
Towards the navel.
Towards the navel. Right, so we're going to have the patient take a few deep breaths. And guys, it's hard to go into these mannequins a little bit, but you're going to go in. And might it be difficult to actually put it into a real patient?
Yeah.
Oh, yeah.
Why is that?
Probably clenching.
They might not be relaxed. What other obstacles might we encounter?
The impaction.
Impaction.
The shape of the tube.
Hemorrhoids. All right.
Discuss hemorrhoids briefly, Ms. Klauber.
What are hemorrhoids?
Inflamed blood vessels.
Right, tortuous, enlarged blood vessels. Okay. Can you have internal hemorrhoids?
Yes.
Mm-hmm.
Which means they are inside the patient. Can you have external?
Oh, yeah.
Anybody ever seen one?
Yes.
My
It's
patient had got one Sunday.
It's a surprise usually if you've never seen one and you see one. You're like, what's that?
Can they be fragile?
Yes.
Yeah.
Yeah, and bleed?
Mm-hmm.
So can you still do an enema on an external hemorrhoid?
You just have to go around it. You just have to be
Careful.
careful.
We put a little bit more lubricant?
A little bit more lubricant. Yeah. Okay. So once you get it in, and I'm going to put my cap right there. Once you get it in 3 to 4 inches, I hold the tube. Do you think the patient can push that out?
Yes.
Yeah, they can. So you want to hold the tube in place. You're going to unclamp it and let the water start flowing in. Once it starts flowing in, I like taking it off of the pole so that I can adjust the height. And that's going to be one of the things. We're going to have you actually fill up your bags with water and see how the flow is regulated by your actions. Okay? I'm coaching the patient, tell them to take deep breaths. How long do you think this is going to take to flow into the patient? So, it probably will not take that long. About 5 minutes. Has anybody ever administered an enema?
Yeah.
Large volume?
When I assisted,
Not large
they kept,
volume.
When I assisted, they kept stopping and restarting.
Right. If the patient cramps, I'm going to lower my bag, which the flow is going to stop, and run till the patient's
Why would a patient start cramping, do you think? Too fast or what?
Going into the colon, so it's irritating.
It's supposed to irritate the mucosa, right? That's what an enema does.
Right.
But let's say that the fluid comes up against fecal matter that's formed and it blocks it. And it starts stretching the bowel right there, right? So that's why you slow down and you let it slide around or ooze around.
Can you imagine that?
Mm-hmm. You gotta kind of visualize what's going on in there. Because too fast, it will just blow up their intestines, their colon. It'll bulge out, and that's uncomfortable.
That makes sense? So if we slow it down, then that will give that fluid opportunity to kind of work its way around that stool. Because where's the bulk of the formed stool going to be? Low in the colon, right? And we really would like to get that fluid around it to dilate the bowel and help flush it out. So if the patient complains, I'm going to stop, let them take some deep breaths. Once they're okay, we can resume it. Once they start taking it again, if they start complaining again, usually when they start complaining the second time, we will stop and end the procedure. Okay? But you want to get most in as you possibly can. Once we get it in, I hang the bag back up, I clamp off my tubing, and then I tell my patient to take a deep breath, and I'm going to pull the tube out. And they're going to get the sensation that not that this tube is coming out, but that their feces is coming out. So I like to hold the cheeks together and tell them this is tube sliding out. It's out now. We're going to wipe them up, position them. If they can hold it, we let them hold it. Most of the time, they're going to be ready to go. Okay, we're going to help them to the restroom. Position them. When you're giving the enema, what other things are we going to be assessing about our patient?
The skin, like if they're dizzy.
Their skin. What about their skin?
The color.
Huh?
Breakdown, any type of irritation.
Yeah. You mean like on the back and the sacral area? Good. What else?
Heart rate.
Power. Why?
I mean, they haven't been able to go. They're probably pretty ill or something like that.
Okay. What else?
That was a good one, Kathy.
Heart rate.
Heart rate.
Why? Stimulates the nerve. So, am I going to be taking their pulse during the procedure?
No.
Probably not. But I'm going to be looking at the patient. Do they seem dizzy, short of breath? Do they appear faint? Those kinds of things that would indicate a drop in their pulse.
Could they die?
Yes.
Yes.
I had a patient, put him on the bedside commode. He was constipated, but not terribly so. He just had difficulty going. The doctor says, what happened, I left him, and he was fine, talking. Went back to the nurse's station, the CNA, maybe 30 seconds later, a minute at the most, went in, opened the door, turned right around and looked at me and says, come here. And you know, you can always tell when they're serious. I went running straight over there, and he was leaned over the bed, and he was a DNR, so we didn't call it code, but he had vagal down and passed away. That's what the doctor said happened.
Question. So when I'm pulling the enema out, am I trying to lower the bed too? Because you know how slow those beds move. What if my
You
patient?
can, if you're good at multitasking.
Okay.
That'd be a great thing to do.
All right.
Lower the bed, you're gonna have his slippers and his robe right here. We're ready to go to the bathroom.
It seems like every procedure you do, y'all, there's some kind of something that can be associated with it. So all of these things seem like common sense and easy, but a lot of times they're not. The simplest thing.
So we're not gonna have a formal check-off with this skill. Just like putting each other on the bedpans, we're gonna let you get up and we're gonna let you practice. If you feel comfortable with that, that will be your check-off. And we will walk around and make sure. Does everybody need to open their enema bag?